Let's see about fibrous dysplasia. What is fibrous dysplasia? Fibrous dysplasia is a skeletal developmental anomaly of the bone-forming mesenchyme that manifests as a defect in osteoblastic differentiation and maturation. Etiology. The exact cause is unknown. It is not believed to be hereditary. It is usually caused by mutation in the GNAS1 gene. Clinical features. The following three disease patterns are recognized: monostotic form, polyostotic form, and craniofacial form. Monostotic form. 70 to 80% of the fibrous dysplasia are of monostotic form. The degree of bone deformity is less severe compared to polyostotic form. Location: ribs, femur, tibia, craniofacial bones, and humerus. Leonchiasis ossea is the name given to fibrous dysplasia that affects maxilla and gives the patient a leonine appearance. Polyostotic form. 20 to 30% of fibrous dysplasia are of polyostotic form. Location: skull and facial bones, spine, shoulder girdle, ribs, femur, tibia, pelvis, upper extremities, and clavicle. Dysplasia may be unilateral or bilateral. It affects several bones of a single limb or both limbs with or without axial skeleton involvement. The structural integrity of bone is weakened and weight-bearing bone become bowed. The curvature of femoral neck and proximal shaft of femur markedly increase, causing a shepherd's crook deformity, which is a characteristic sign. Craniofacial form. This pattern of disease occurs in 10 to 25% of patients with monostotic form and 50% of patients with polyostotic form. It can also occur in an isolated craniofacial form. Oral manifestations. Mandible is commonly involved. Expansion and deformity of jaws and the eruption pattern of teeth are disturbed because of loss of normal support of developing teeth. Endocrine disturbances may also alter the teeth eruption. No intraoral pigmentation is reported. Radiographic appearance. Radiographic features are extremely variable. Unilocular radiolucency, multilocular radiolucency with a relatively well circumscribed border and containing a network of fine bony trabeculae which gives typical mottled appearance. Many delicate trabeculae in different directions get superimposed, giving rise to ground glass appearance. The lesion merges with adjacent normal bone. Histopathology. Fibrous connective tissue consisting of proliferating fibroblasts, compact stroma of interlacing collagen fibers. Chinese letter or C-shaped irregular trabeculae of bone are scattered throughout the lesion. Osteoblastic rimming is absent. Osteoclastic activity may be seen in few areas. Treatment and prognosis. For smaller lesions, surgical resection. For larger lesions, removal without extensive surgery. Thank you so much.